excellent talk too, we have Dr. Albert Chen, who we all know, of course, because he's a GP and a geriatrician. I know he calls himself a gerontologist, but that's American. And I stick to my Britishness, try to. He's a medical doctor and a consultant clinical gerontologist, which is a specialist in the study of aging. He completed his gerontology training at the Leonard Davis School of Gerontology and the Ethel Percy Andrus Gerontology Center at the University of Southern California. He's president of the Alliance on Aging in Jamaica and the chairman of the Alzheimer's Disease Outreach Program, and has excellent programs I'm sure we've all been to. Dr. Chen is the recipient of the 2004 President's Award of the MAJ. He's a member of the MAJ, the Caribbean College of Family Physicians, the American Association of Geriatric Psychiatry, and the Gerontological Society of America. I hope he joins the Association of General Practitioners too. He has made many local and international presentations on aging-related issues and has published papers on adult sexuality, successful aging, and dementia. And he's married, of course, to one of ours, Dr. Delini da Silva, and they have 3 children, and I don't know how he manages all of that. Thank you so much, Albert.
Thank you very much, Dr. Sloper. Good morning, ladies and gentlemen. I want, first of all, to thank President Swaby and his team for inviting me to share the morning with you and to share the podium with my esteemed colleagues. As I look at the topic, I have no choice but to try and understand what exactly is going on in the minds of the leadership of the association. Why do you invite me to speak about dementia at this time? And I'm going to try and find a few reasons why Dr. Swaby might have chosen this topic. This slide gives us an idea of the prevalence of dementia in those over 60 worldwide. It forms part of the World Alzheimer's Report for 2010. As you can see, the highest prevalence of dementia is in the Caribbean and Latin America, just over 8%. As Jamaicans, we fall both in the Caribbean and in Latin America. So you could see that, thank you, our goose is properly cooked. Again, the next reason why Dr. Swaby might have invited me is because he realizes that the number of persons with dementia worldwide is slated to increase dramatically, especially in low and middle income countries like Jamaica. Reason number 2. Or maybe it's because he realized that the number of persons with dementia will almost double in the next 20 years. Reason number 3. Maybe he's aware that the cost of managing dementia exceeds the annual budget of Walmart and ExxonMobil. Reason number 4. Maybe he realized that the annual cost of managing dementia equates to the 18th largest economy in the world, somewhere between Turkey with a population of 75 million and Indonesia with a population of about 245 million. These, I believe, are some of the reasons why Dr. Swaby decided to invite me. But there might be another reason. He might have realized that regardless of the stage of dementia, there's a significant disparity between the number of persons with dementia, the number of persons diagnosed, and the number of persons being treated with a cholinesterase inhibitor. Mild, moderate, and severe all show severe disparity. But when I thought about it, I realized that there is an even bigger reason. Dr. Swaby realized that 80% of all dementia care takes place in the offices of primary care practitioners. This is not because our primary care practitioners are the best qualified. They might be very qualified, but this is because older patients are more comfortable getting their mental health care from their GPs. So, the numbers are telling us a story. We can run and we can refer our patients with dementia anyhow we want, but the patients are coming back to you. 50% of those we refer to a psychiatrist or neurologist don't go. Of those who turn up, 75% don't go for a second visit. I believe Dr. Swaby is right that we really need to start looking seriously at how we manage dementia. This is a part of the work that we are going to face in the future. So, the discourse has somehow changed over the last few years from Alzheimer's disease to dementia for obvious reasons. What is dementia? I always think of dementia as end-stage brain disease. It's very difficult for us to treat dementia simply on the basis of a diagnosis of dementia, but it's somewhere from which we begin. You cannot help these patients unless you make a determination that they are demented. So what is dementia? It is an acquired mental deterioration lasting for over 6 months in older persons. So it must be acquired, it must last over 6 months, it must impair their normal activities of daily living. Otherwise, they're not demented. If they have had this mental deterioration all their lives, they, as I mentioned before, are not demented, but mentally retarded. So, what leads to this mental deterioration? Almost anything, many things. And it is in elucidating the cause of the dementia that we are able to intervene clinically. Many of the dementias we see are neurodegenerative, such as Alzheimer's disease, Pick's disease, and so on. But it really doesn't matter, especially when we're looking at patients with severe dementia. The clinical picture is pretty much the same across the board. Here we have some of the common causes of dementia. Alzheimer's disease, of course, but strokes, Parkinson's disease, Lewy body, other non-CNS, Wilson's disease, chronic renal failure, AIDS dementia complex, vitamin deficiencies, traumas. There are many factors that can lead to brain incompetence. And when we make the diagnosis of dementia, we are forced to make the next step. What is causing this dementia? Now, common things occur commonly. So let us deal with the most common forms of dementia. Depending on the study you look at, Alzheimer's disease accounts for about 65% of all cases of dementia. And then Lewy body, vascular dementia, and frontotemporal dementia account for the next 30%. Together, they make up about 95% of all cases of dementia. How many of us are making the diagnosis of Lewy body, frontotemporal, or vascular dementia in our practices? Are we still diagnosing everyone with Alzheimer's disease? Today, I just want to have a discourse with you, and I should have said this before. My aim is not to teach you anything new. In fact, much of what I will discuss can be referred to as off-label management of dementia. You've read the books, you know everything. I just simply want to give you a new perspective on how to look at dementia. It appears to me that as we get older, we become unable to remove a lot of the insoluble precipitates in our brain. This is normally done by the microglial cells, and there seems to be a microglial dysfunction which accounts not just for dementia, but for depression and many other and epilepsy and many other conditions in older folks. These precipitates, these particles, insoluble particles, accumulate. Where do they accumulate? Well, depending on where they accumulate, we get different clinical pictures. Is it important for us to know what particle is to be blamed in each specific case? Let's look at it. We have heard about beta amyloid, tau, Higgs body, Lowe body, alpha synuclein, and all these other particles. It's not really a whole lot. Beta amyloid, especially the toxic beta 42 fragment, and tau are implicated in Alzheimer's disease. In Lewy body disease and Parkinson disease dementia, we have alpha synuclein and ubiquitin. In frontotemporal, Higgs body containing tau again, ubiquitin, alpha synuclein, and apolipoprotein. In fact, in normal brains, you may find all of these precipitates. What is important for us is not the precipitate. What is important for us is the neurochemical change that they cause. These changes lie at the clinical picture. And until we are able to clean these precipitates out of the brain, we have to focus on the neurochemical changes. We need to understand how they express themselves clinically so we can determine how we manage our individual patients. Having said that, today we speak about cholinesterase inhibitors as management for dementia. In other words, we focus predominantly on a deficit of acetylcholine. We know that neurotransmitters function in a cocktail. Any single function may depend on 4 or 5 or more different neurotransmitters. It is therefore unreasonable to assume that the clinical picture in our dementia patients can be improved by focusing only on one neurotransmitter. The other point I want to make is that when you look at the points in the brain where these neurotransmitters are formed, they are all formed in pretty much the same areas. The basal forebrain, brainstem, hippocampus, amygdala, basal ganglia areas, hippocampus, ventral tegmental areas. They are all formed in pretty much the same areas of the brain. A very small area of the brain. It appears to me that it doesn't matter so much what the precipitates are. What matters is the areas of the brain where they predominate. But because they are all in these small areas, this small location in the brain, it is not difficult for these precipitates to move from the hippocampus over to the substantia nigra. And therefore, in severe dementia, we get a picture which includes almost everything. The other problem we have is that there are highways in the brain that carries information from subcortical to cortical areas and in reverse. Let's imagine that we have Kingston and Montego Bay. All water is produced in Kingston and must be taken to Montego Bay. If you want to starve Montego Bay, you can bomb Kingston. No water goes to Montego Bay. But you can also block the road. If there's one main road to Montego Bay, you can block that road. So, a simple stroke anywhere in the subcortical areas blocking this transmission point can give you pretty much the same picture as if the entire cortex was involved.